Hello, hello. How are you guys today? Okay. Oh, sorry, there might be a little feedback here. I'm gonna mute myself because I wanna move my I wanna be able to screen share from my computer, so I've gotta give my personal account Zoom access here. Okay. I think I've got this figured out. Is anybody getting weird feedback? Okay. So I am Jennifer. I am the director of curriculum for the Pacific Birth Institute, um, along with Jessica Johnson, the director of development. And today we are going to talk about documentation. We have just done a ton of work to create a whole bunch of documentation templates so that um, for people who need to build documentation templates into their EHR or are using paper charts, that they don't have to create from scratch when they're first starting out. They're also really good for birth assistants to take with them to practice charting or to be able to just have printed out so they can write stuff down so that midwives can take that information and then put it into their official chart. So I'm going to show you guys a few of the templates that we have created, go through scenarios, and show you examples of documentation. So, um, before we get started, though, I do want to remind everybody that we do have the conference in Hawaii in January of next year. That is, um, tickets are for sale right now. We are shooting to have 15 CEUs for that. So it's going to include things like documentation, medications, um, suturing, so all that sort of stuff. We've got on-site spaces to stay, so there'll be like after hours that things with Jess and I, on-site chefs preparing meals for us. So it should be a really fun, exciting time. So definitely check out pacificbirthinstitute.com for more information and to take a look at the venue space. It is an absolutely gorgeous house. Um, Super excited about that. And then also pacificbirthinstitute.com, you'll be able to access all of our charting templates as individual, like one-off templates if you just need a good prenatal one, or if you're just looking for like consent forms for prenatal labs, ultrasounds, 28-week labs, that sort of stuff. Um, Admission and labor notes. By the end of the week, we should have the postpartum follow-up notes and some well woman stuff added to our bundles. We're gonna package some together, like a prenatal package, a labor package, a newborn package, postpartum package, and then a package of all of them all together. So definitely take advantage of that, especially for new midwives and small practices that are just starting their own gig. Don't try to rebuild everything from scratch. So that's a lot of work. Um, so today what we're gonna do is I'm going to use the documentation system that I use, Client Care, to show you how these templates can be put into that specific documentation system and their template I don't know, algorithm and use that. And then I'm also going to show like a copy paste how you can just put it in a blank Google Drive if you're paper charting. Um, And you can either like add some spaces if you just want to print off blank ones and handwrite in it, or just put it in a Google Doc so that you can type in each prenatal visit, print it off, and then put it into like a paper chart record. So, first, let's talk about why do we do documentation? Um, of course, we want to have an accurate record of what's going on with each client, right? We want to be able to open the chart, review the history of what's been going on with that patient, look back at their labs, um, acknowledge any complications that's going on with a client, easy access to know their blood type or history of significant problems with previous deliveries so that we can make sure that that is all part of our anticipatory guidance and planning for birth. So we want that. Um, Another reason that we document is, especially for those of us who are billing insurance companies, a lot of times insurance companies will want documentation to, um, it's prove, I guess, for lack of a better term, that what we are billing is supported through the documentation, that the level of care for each visit is supported through documentation, that the procedures and medications that we gave are documented, things like that. Um, then another reason to keep good records is in the event that we have to transfer care from either prenatally, if complications arise, like difficult to control gestational diabetes, um, intrauterine, like fetal growth restriction, hypertension, preeclampsia. So you've got a complete record of everything you've done so far with your client, all their lab work, their ultrasound, so that can be given to a higher level of care provider. Or if we have to transfer in labor or postpartum, that everything is written down, and so that the team that's taking over care for this client will have like a narrative story of what's been happening since your first encounter with them through pregnancy, through their labor, their birth, if you've delivered, especially if it's like a baby transfer, so that they can look back at the mom's records and know, is she immune to hepatitis B? Have we tested her for HIV? What did the baby look like when it was born? What resuscitative measures have already been taken? So all of that is written down in a timely manner. Um, so those are the big reasons that we take care of charting. And then the one that nobody likes to talk about is that if for some reason we ever got called into a court of law, that we have records reflecting what we did, that we offered our clients a standard of care, risks, benefits, alternatives, and documented their choices so that we can defend our position and our choices that were made. Um, and the unfortunate truth anytime you're working in a birth space, you have to remember in the United States that we do maintain liability for every baby we deliver for 18 years, which means that you need to maintain your medical records for 18 years after every delivery. They need to be accessible. You have to be able to respond to requests for medical records or subpoenas. So those records need to be kept in a safe space. And generally, I recommend that everything is scanned and kept on a hard drive, in a cloud. Um, if you're a paper person, then also your original paper record. I personally don't use any paper records of any kind, so I've got the documentation system I use, they back up themselves, so which is really nice. So there's redundancy in the saving of my records, so they're available. If you ever change documentation systems because they're all like subscription based, you will need to download like PDF copies of all of your patient charts and save them on a physical like hard drive as well as like in a cloud space so that you always have access to them. Anybody have any questions so far before we dive into a few examples of documentation? You can either just unmute yourself and ask or type in the chat. I can see all of it. And I've never done a screen share before, so we are gonna see if I can figure that out. I use client care. Adrian is asking what systems do I use? I use client care. I have used maternity neighborhood, I think is what it was called in the past. I definitely find client care to be much more user friendly. Um, so that's my preferred one. It's also significantly less expensive. Sorry, guys, give me just a second here. Made myself the host so that I could screen share with you guys. And I don't have a screen share button on this, and I've seen it before, and now I don't know what I'm doing, and I feel dumb. All right, give me. If anybody's really good at Zoom and knows where my screen share options are, because I am not seeing it on my screen, I would love for you to hop on and talk me through this because I feel like a boomer right now. Okay. Oh, got it. I think. Okay. So, so we are gonna look at some of our templates. Um, if anybody is not seeing my template, like my computer screen, please let me know. So let's start with do 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 do. Just like let's go here. These ones look better. Routine PD, like when we're talking about medications with mom, late in pregnancy, like 37, 38 weeks. So this is what our charting templates look like. Up at the top here, it'll tell you what the template is, and kind of where in your document, like your documentation, it needs to go. So like if you have a paper chart and you keep it in sections of like you've got your prenatal, and then you've got your labor section, your postpartum, and your newborn. So this will kind of tell you where it goes. Because this is a specific prenatal visit, this is something you only need to do once. Whereas like a routine prenatal visit, it'll say every encounter or newborn follow-ups, every time you see the baby, that sort of thing. Um, and so each of our charting templates comes with a scenario. So like in this one, we have a 38-week prenatal visit at the birth center with a CPM. We have a 32-year-old client who's a G2P1 at 38 weeks, and we're going to talk about newborn medications and vaccines. Um, and so she comes into the clinic and the midwife is, ask her normal questions. It's important to review medications and vaccines that are administered to newborns after the birth. Let's take time to discuss it. And so then you can see the client has some questions. The midwife answers questions, especially like this one specifically into vitamin K. Like, why do we give it? What are the risks, the benefits, the side effects? What is K deficiency bleeding? How often does it happen? Um, and so you can kind of see an example of how you talk to your clients about these things. And then, uh, then you can see where the midwife and the client kind of come to an agreement. So then like this shows how you would document that sort of a thing. Um, you know, 32-year-old G2P1 at 38 weeks presents for routine prenatal care. She's got no contractions or signs of labor, reports normal fetal movement. She wants information about newborn medications, including vitamin K, erythromycin, and hepatitis. And she understands and agrees to the vitamin K injection, Hep B, and declines erythromycin. A lot of us don't carry vaccines because vaccines are extremely expensive. They expire like pretty quickly, and not a lot of midwifery clients want them anyways. So if I have a client who does want the hepatitis B vaccine, I refer them to their pediatrician's office to get it. It is our responsibility to talk to them about standard of care. So it doesn't matter if I like or I hate vaccines. My opinion doesn't matter at all. It is our job to tell them this is the standard of care. This is what like NARM recommends, this is what ACNM recommends, this is what ACOG recommends, this is what the CDC recommends, this is what American Academy of Pediatrics recommends. These are the recommendations. This is the information about this vaccine. This is why it's recommended at this time. These are the potential side effects, these are the potential benefits. And to give patients written information about vaccines, which is totally free and available from the CDC website, and then allow parents to make their own choice about the vaccines. Putting any of our bias into the information is not only unethical, but if you are particularly anti-vax and you provide information that leads parents in that direction, and then their kid were to get, like, especially in Texas right now, say you don't like the MMR, you have issues with it, you let that bias bleed into your counsel with your clients, and your client their baby gets the measles, you could be held personally liable for that because they said, well, my midwife said that this was problematic and they trusted you. So you have to be so non-biased. Like, this is just factual information. And if they ask you, well, what would you do as a provider? Your answer has to be like, this is the information I can give you, and it doesn't matter what I would do. You have to take this information and integrate it with your value system, and you have to make the decision for your baby. I can't do that for you. Like, as simple as that. Like, you really, truly have to take all of your own bias out of it to avoid liability. And it's unfortunate that in the United States of America, like that is something that we do need to be like significantly concerned with. It's important to just be as objective, risks, benefits, alternatives, and then just go from there and let it be. So, so all of that was like the subjective information. So our SOAP notes, right? SOAP is subjective, objective, um, assessment, which assessment means diagnosis, and then plan. So what we're gonna do, what we talked about, that sort of stuff. So in the subjective piece, she wants to know more information. She reports feeling like her baby's fine. It's moving around. She's not having headaches. Those are all feeling things. Our objective section is measurable stuff. So in here, whoa. My touchscreen computer is being exciting today. So in here we've got our blood pressure, heart rate, your fundal height, your Leopolding where you feel the baby. Um, sorry, it's springtime in Alaska and all the trees exploded and I'm allergic to life. Um, so baby's position, baby's heart rate, if you see any physical signs of edema, and then if you're a provider who does routine urine dips, like in Alaska, um, the CPMs are required to do a urine dip at every visit. I don't do them at all unless they're symptomatic because there's no scientific evidence that supports routine urine dips, so I just don't do them. I think it's a waste of resources, and if you go looking for problems, you're more likely to find them than if you follow symptoms. Um, and then in your assessment is your diagnosis. And it's super important that, especially if you're billing insurance or providing super bills, you have to have like ICD-10 codes that go with it. There's a million ways to look up ICD-10 codes on Google. I usually use ICD10data.com. Um, and so you want to use as many codes as possible so that you're specific as possible, so that you support the billing that you're putting out there, whether or not you're directly billing the insurance company or you're providing your client with a super bill so that they can get reimbursed from their insurance company. Because this supports the complexity level of the visit. Because in this, you're counseling, you're spending a lot of time talking about this sort of stuff. That makes your visit longer. That makes your visit more valuable. That your time is valuable. So you want to be able to say there's a reason I spent 45 minutes with this client, and so I deserve to be paid for a 45-minute visit with this client. And then what's your plan? So we talked about the vaccines. What do they make a decision? And then schedule their next visit, that sort of a thing. And then you would sign your chart. So that is that template. And then within this, we provide you guys with a blank template that you can copy and paste into a blank Google document, or you can use it to put into like a EHR system. So, um, this one's not a great example for client care because it does have significant like templates just built into it that cover like all of the gestational age and all that sort of stuff is put into client care by itself. So you don't really need to do that for this. So I will. Let's see. So in client care, when you want to build a template, for example, you go into with this one, it's you go to manage account. So I had to be super zoomed in so I didn't like show any client data. And then it's in account settings. And then over here in this templates tab. And then so I can show you like here. So like I have a template for my ultrasound order. And so when you're creating a template, you can type in the field and then see all these fun little buttons over here. This will pull data from your patient's chart and insert it for you. So like I typed in obstetric ultrasound order 4, and then I just went over here and clicked the full name button. And so now when I use this template in any patient's chart, it will automatically pull that patient's full name in and their birthday, the client's phone number, their LMP, their due date. And then over here, when I pull it up, then I just type in the type of ultrasound. I put in there, so if it's a dating scan, Z34.01 for first time pregnancy, first trimester. Um, and then whichever provider is currently logged into the system and writing the order, their name will auto-populate there. And then just all that. So it's really nice. It's really convenient to be able to create all of your own templates. Um, so if I was in to let's see. I know we don't have one of these in my system. So let's look at like a phone call. Let's be Again, why are we documenting things? We want to document every single time that we encounter with a patient what was said and what was done. I know it's really easy to think, well, like this text or this phone call that I got from a client, it didn't matter that much. I'm going to see him in the clinic later, but you really should document every single interaction you have with a client. Super important actually to interact or to document every single interaction you have with your clients so that again that like she slipped and fell on the ice. I recommended that she go in to OB triage for monitoring. Um, if you don't write it down that you recommended that, and then she doesn't go in and she has a placental abruption, you like have no ground to stand on. Like you can't go into court and be like, no, I talked to her on the phone, and see you can see on my phone records right here, but if it's not in the chart, it's not done. So this scenario is like somebody calling saying they're in early labor. It's kind of uncomfortable. The midwife recommending that, just stay in touch. Let me know when things get, more uncomfortable. If your water breaks, if you feel like your baby's not moving, all that sort of stuff. Um, and so then I created just like a phone call template. Like, so let me show you like how you could use this to create a template within inside your EHR. So copy and paste it, right? So highlight it all, Control C is copy, and then I'm gonna go back into my template creation here. Yeah, it's not a letter, this is a chart note. And chart template, brand new. What is this? This is gonna be like client early labor phone call. And then Control V, just paste it in. So this will automatically save the date of it when you create it. So date, but you do want the time. So right here, client name, I'm gonna get rid of that line. And then I can just hit full name. And then there, gestational age right there. And then, ooh, G's and P's on here is a thing you can stick in. I don't think it is. So I leave that one. And then right here, get rid of that line. And then I can click provider name. So that will all auto-populate. And then in here, you've got prompts of things to ask when you're typing. And so you can just save this and then it's available. And so then when you pull it up as you go into like your prenatal notes, you pull this up and all of this is removable. So you could like, when it's in there, you just click it and you back it out and type in whatever you want. But these are nice prompts to remind you about what to ask for. So it's all there visually stimulating your brain because you know when you get a phone call at 2 in the morning, it's sometimes a little hazy. And so that's a nice thing to be able to look at and jog your memory of everything you need to ask and think about. That all make sense? Questions? So some of the templates that we currently have available that are done, um, third trimester, like informed consent, so reviewing risks, benefits, alternatives to gestational diabetes testing. Um, then the 24-week prenatal is like the specific discussion that you would want to go into to obtain the consent. Um, and then 36 week. So you have one for like a home visit prenatal versus a birth center. Home visit prenatal, you want to make sure that you document that you have observed the space that the birth is going to be in and that you've deemed it a safe and acceptable place. Like I live in Alaska, and sometimes I've definitely been to places where people have told me like, oh yeah, our road's plowed regularly, it's easy to get to. And then I get there and I realize these guys are driving like a 4x4 and like it's super steep and not super well maintained. I'll be like, no, this is not a safe place for a home birth because I need an ambulance to be able to get here. And I can't guarantee that. Or it's like I don't want to get stuck in your driveway and then I'm in the way of an ambulance, that sort of stuff. Or homes that I did one out in Girdwood, which is like a little ski town here, and another midwife had done their 36-week visit. And I get there, and it's a dry cabin. There's no running water. And for me personally, being an hour away from the city and not having access to running water, I would have not been comfortable doing that birth there. It just seems like not the safest, best situation. But you want to make sure you're looking for things like drug paraphernalia if you live in a place like that. We had a midwife one time that just before she arrived at a birth, client was in labor, got shoved into a bathroom and held at gunpoint while her drug dealer husband was robbed. So you just want to be making sure that your surroundings are safe, that you know how to get where you're going so that you're not trying to find it on your GPS for the first time in the middle of the night while she's having contractions. So you want to make sure you're documenting that in your 36-week visit. Um, and then the birth center visit is, just doesn't have quite that much information in it, but both of them go over like all of the reasons that you would transport, how we do non-emergent transport, how we do emergent transport, reasons that we transport in labor, reasons we transport for a mom after delivery, reasons we transport for baby after delivery, all that stuff is in there. Um, and then there is one that talks about a prenatal that's like a regular prenatal visit, but then talks about group B strep, and why we test for that, risk factors, um, and so that you can talk to the clients about what it is. And these scenarios are really nice because it does give you kind of a working script to kind of practice with. So, like the midwife here is like GBS is a common bacteria that about 25% of pregnant people carry naturally in the vagina or rectum. It's not harmful to the mom, but it can pass to the baby. Most babies do fine, but in rare cases, it can cause serious infections like pneumonia, sepsis, and meningitis. And those are the big three you want to hit. And then Of course, the client says how often do babies get sick, and like without treatment, it's about 1 to 2%, and with treatment, it drops down to like less than 0.1%. Um, and in my personal practice, I do talk about acceptable level of risk. I say if your baby gets sick and you didn't do the antibiotics, are you going to be mad at yourself that you could have done more? Because if you're one of those people that's like, I want to have done every single thing possible to make sure my baby didn't get sick, then you need to document that. Whereas other people be like, 1% chance, that means 99% chance my baby's going to be fine. And exposing myself and my baby to antibiotics seems like a bigger risk to me. So you need to be able to talk to your patients about both of those things. They can decide if they want to use antibiotics and document that. Um, and so here the midwife talks about options for if the mom has group B strep, increase monitoring of the baby after birth. Like in the hospital, they do vital signs every 4 hours for 48 hours. So you can talk to the mom about how she might need to do that. Um, Probiotics and natural remedies to reduce colonization. And then, informed refusal if they decline the antibiotics. Um, and then here, just and how you would document it. Subjective. How old is she? What's her G's and P's? How far along is she? Just normal, no contractions, no signs of preterm labor, feeling baby move, and that she's wanting information about group B strep. Um, and then your vitals, her weight, fundal height, fetal heart tone, position of the baby, all that. Again, your ICD-10 codes, and then your swab. That you discuss the risks, benefits, and treatment options for it, and then um, encourage your client to review their preferences regarding antibiotics if they're positive. Like they don't have to make a decision now; they have to make a decision in labor. But you want them to start reading about it, thinking about it, and kind of making a plan and coming back with questions next week, that sort of a thing. And then again, your blank note. So you can copy and paste that and plug it into a chart template in an EHR or just a regular Google Doc. Um, or if you're gonna just print them out, like I really love these for just printing them out because they've got just little check boxes. You just check, 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 um, and fill it all out. Questions? What kind of documentation systems do you guys use or have you seen? Do you guys use paper charts where you're at? I work with one midwife that she does kind of half paper charts and half electronic charts. So she's got like her labor flow that she does in labor. Um, and then instead of documenting in her electronic medical record system, she just really likes her paper charts. She just scans them and then inputs that as a scanned document attached to her patient charts, which is totally fine. You have to remember if you are billing Medicaid or Medicare, you are required to use some sort of you have to have electronic medical records. It's just a law. Adrian is using paper. Christina, do you like client care? Have you done much like chart template customization within the system? Or do you just use their kind of pre-loaded ones? Because client care does come with a ton of preloaded templates that are very, very nice, very useful. Um, and Like I've created like all my ultrasound orders, lab order templates, physical therapy referrals because I every single one of my moms at post delivery, I give her a pelvic floor physical therapy referral. So like at the birth and I'm like doing all my other paperwork, like their verification of live birth for their insurance company is another template I made. I'll fill that out and then email it to them so they just have so they can pick their physical therapist and just take it with them to set up their appointments, stuff like that. So I find it to be extremely user-friendly system that I like a lot. Maternity Neighborhood is basically just blank space to type in with blocks to input your vital signs. And so the copy and paste into the client note is super helpful. That was the first system that I used, and so I actually um, just created Google Docs for my different types of visits, and then would copy and paste those. Yeah, cool. Any other questions? Things you guys can think about documentation? I would say just, especially for student midwives, apprentices, practice, 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 practice charting. Um, oh, I don't know jot form. So I haven't used that one. Um, but even if you're just printing it off and just writing it down and then ask the midwife to review, like, how would you have charted this? Did I chart this correctly? Just to get feedback on it because I feel like apprenticeships kind of go one of two ways. Either you end up just watching a ton of stuff and then doing vitals and cleaning a lot in the beginning, or you get sat behind the computer and told to chart everything. But it sometimes don't feel like there's a ton of teaching that goes on behind it. So especially in your first few bursts where you're really just watching, practice charting, just write stuff down and then ask for feedback and pointers on how that went well. But remember, when you're a student, the ultimate responsibility of the correctness of your chart is in the hands of your midwife. And it is, remember I was showing like in the assessment portion, the ICD-10 codes, it is illegal for anyone other than a midwife to input a code on a chart. Your biller cannot put a code on your chart. Your apprentice cannot put a code on your chart. Your birth assistant cannot put a code on your chart. Only a credentialed healthcare provider can put codes in charts. So you can write down first pregnancy, third trimester, but you cannot put down the Z34.03. Like it'd be like billing. It just it's fraud if you do it because you're not credentialed to make that assessment. So you can write down nausea, back pain, all that sort of stuff as like a flag for your midwife to go look up those codes, but super, super illegal for anyone other than a midwife to type codes into a chart. All right. Well, that is pretty much all I have to say about documentation. Does anybody else have any other questions before I sign off and let you guys go and enjoy these lovely spring days? All right. Well, visit pacificbirthinstitute.com if you want access to these documentation bundles. It pacificbirthinstitute.com. It'll all be on there. It's all downloadable. It's a click link straight into our, it gives you access into our Google Drive to each document and each bundle so that you'll be able to download those. Um, And next week, Jess will be back with you guys. I will be in Florida for All-Star World Cheerleading Championships with my 17-year-old son and my 15-year-old daughter. So lift them up, send all the positive vibes for them. And I will see you guys back in 2 weeks. Thank you. They'll have fun. It's going to be super fun.